Good evening, everyone. Welcome, 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 and a big welcome to everyone. This is a large audience, and we are pleased that you're here with us now. And let me introduce myself. I am Dr. Arna Brown-Morgan, your moderator for this evening. I am an executive board member of CCFP Jamaica, and I am also a member of Doctors for Change Jamaica, whose membership actually advocated for this very needed webinar on the current flu viruses, which has affected so many of us. I currently myself have 2 family members with pneumonia from the virus, so I admit to a very strong personal interest. Our speakers this evening are very, very highly qualified to speak on this topic. So I am just without ado, and seeing as we're a little bit late, we're going to get on with the program. And we would like to start with prayer from Caribbean College of Family Physicians Executive Board Member, Dr. Arlene Henry Dawkins. Dr. Dawkins, please. We pray.
Good evening, everyone. May we honor the Lord God as we pray. Awesome, wonderful, Almighty God. We are so grateful for your care, many blessings and grace towards us. Lord God, may we always remember your faithfulness and love for us. And so we want to welcome your holy presence among us. We are thankful for this opportunity for the Caribbean College of Family Physicians Jamaica to host this webinar so various important information can be shared and discussed about this relevant topic of the advent of the flu virus. These diseases are concerning as we become aware of the rise in number of cases in our country, which are increasingly affecting the health and well-being of families here. So, Lord God, we ask for your insight and guidance as we listen to the presentations and pray for focused and clear minds to retain all the information imparted by our expert presenters today. As we learn and engage in discussions, may we become more confident to efficiently manage the patients presenting with symptoms of the flu virus. So, Father, we pray for unity as we work effectively to achieve the best outcome for our patients. We pray for good health and protection of all health workers as they interact with them and the public. May there also be quick recovery and healing for those who became ill because of this flu infection. Graciously bless our facilitators with clarity of communication that we may gain understanding to apply all learned to our practices in meaningful ways. We pray for effective functioning of the audiovisual system and undisturbed transition of the sessions throughout the meeting. Pour your blessings on the technical team, sponsors, and moderators as they perform their various duties. Grant that another excellent webinar will be enjoyed and the impact significant in our daily practice, Lord God. May your blessings rest on each participant as they give up their time to meet on this virtual platform for the benefit of everyone in their care. All these we humbly ask through Jesus Christ and the Holy Spirit. Amen.
Amen. And we would like to just thank Dr. Arlene Henry Dawkins for this wonderful prayer, which brings us all together as doctors, patients, people in the community who are suffering, who have suffered, and who are just want to share in knowledge so that we all can manage better. We can manage what is happening in our community better. Thank you, Dr. Dawkins, Dr. Henry Dawkins, for such a lovely and focused prayer. It is now for me to hand over to Dr. Celia Christie, who is the president of the Caribbean College of Family Physicians, Jamaica branch, to say to you her welcome and her greetings. Dr. Seni, over to you, Doctor.
Good evening, everyone. To begin with, I hope you are hearing me. Hello? Am I being heard?
Yes.
Good evening, everyone.
Yes, we're hearing you, Seni.
Our special invited guests, Professor Celia Christie, Doctors Karen Webster-Carr, and Cathy Ann, Pate Robinson, moderator, Dr. Arna Brown-Morgan, our apologies. Dr. Arna Brown-Morgan, our moderator, esteemed colleagues, locally, regionally, and internationally, friends, ladies and gentlemen, a pleasant good evening to you all. It is indeed my pleasure and honor on behalf of the Caribbean College of Family Physicians to bring you greetings and welcome you to this our first webinar for 2026 on cold and flu under the theme, the advent of the new flu virus, beyond the common cold, confronting emerging strains. Are we ready? This came into being because the members of the CCFP and the Doctors for Change, which was formed about 6 years ago during the COVID time, were worried about the rise of the virus, of the flu virus, as it had never been that bad in our region recently. So every year we are confronted with seasonal flu illnesses. This year, 2026, the surge has been more significant, causing ill health, increased job and school absenteeism, as well as increased doctor's visits and hospitalization. This has not gone unnoticed, and at this time, as this flu was different from what we are traditionally accustomed to. It became the catalyst for organizing this evening's webinar, and as our moderator told you, it was a discussion between the CCFP and the Doctors for Change, JA. This evening's webinar is intended to provide healthcare professionals with the latest clinical updates on emerging influenza virus strains, Participants will learn evidence-based approaches to diagnosis, management, prevention, and outbreak preparedness to strengthen clinical readiness and prevent vulnerable populations from illnesses and severe illnesses, and actually from death when necessary. As such, we have presentations to be delivered by knowledgeable and distinguished presenters, Professor Celia Christie, Professor Emerita of Pediatrics, Infectious Diseases, Epidemiology, and Public Health, Dr. Karen Webster-Carr, Principal Medical Officer, and national epidemiologist, Ministry of Health and Wellness, and Dr. Cathy and Pate Robinson, consultant and specialist in infectious diseases. Professor Christie, Dr. Webster-Carr, Dr. Pate Robinson, we welcome you wholeheartedly. We wish also to welcome Dr. Tenia Whitby-Best, our regional president, and all our participants, our presenters, moderators, and attendees, as well as our IT and technical support personnel who along with CCFP chapter, is a co-host of today's webinar. Our administrator, Lynn Thomas Hyatt, and the planning committee members whose invaluable support over the years have made a webinar such as this a truly worthwhile and successful endeavor. I invite you all on behalf of the college to sit back and enjoy the presentations. And I thank you and God's richest blessings.
Thank you, Dr. Onanuju. It is now my pleasure to introduce to everyone here, doctors and people who are lay people from other professions, Dr. Karen Webster-Carr, who, as Dr. Seni said a little while ago, is the Principal Medical Officer and National Epidemiologist with the Ministry of Health and Wellness here in Jamaica. She's somebody who we know extremely well. Dr. Webster-Carr is somebody who makes herself available to the community, frequently to interact and to share with us things that are pending, coming, answers our questions. She's always there for us. So we thank her today. She has been in public health practice for over 20 years, and most of that time with the KSAC, and has led a large response team to the urban outbreak of malaria 44 years after it was eradicated in Jamaica. And she leads on a number of health programs and policies as it relates to epidemiology and research. She is chair of the Health Thematic Working Group for Jamaica's National Development Plan, Vision 2030, and any number of other things. She is there for us with a response to avian and pandemic influenza in Jamaica, and co-principal investigator for the Jamaica Health and Lifestyle Survey 2016 to 17. So she is critically involved. She was in Jamaica's response to the COVID-19 pandemic. And so she knows how to respond to troubling viral infections. And we're going to ask her now to come on board and share with us the topic being the epidemiology and statistics of the new flu virus emerging strains. Dr. Webster-Carr, over to you. Thank you.
Thank you, Dr. Brown-Morgan. Thank you, everybody, and good evening. It's my pleasure to speak at this webinar, and we're going to go into what's the situation. We'll look at the global and regional situation. We'll speak a little bit about Jamaica's surveillance system and what's happening in Jamaica. So globally, there seems to have been or has been increased influenza activity, and some are reporting early start in the influenza season. And predominating is influenza A, H3N2. And this increased activity is really part of the Northern Hemisphere season, which we are part of the Northern Hemisphere. And so what has been happening, in a very short period, 1 week period, there was some significant increase in influenza positivity, which is what we are seeing here. So the reds and the orange are increases, while the blues are decreases. Then when respect to RSV, the reverse seems to be happening in most places where the RSV is decreasing. However, we are part of the Northern Hemisphere, but there's a Southern Hemisphere. And in the Southern Hemisphere, and particularly Australia and New Zealand, saw extension of their influenza season. And they believe it's the emergence of the influenza A, H3N2 subclade K, and this shows the migration of the influenza A, H3N2. And so it is being proposed that this is the cause of the increase or the extension of the season in the Southern Hemisphere, and probably the early start of the season in the Northern Hemisphere. On the 4th of December, PAHO issued an alert regarding the possibility of early or more intense activity in our season compared to previous years. And by January 9, they had recommended that we are vigilant so that we can, pivot and adjust our health services to be prepared and act accordingly, probably increasing seasonal influenza as well as respiratory syncytial viruses. And in Epi Week 2, influenza activity continues to trend upwards, mainly circulation in the Northern Hemisphere, in the region of the Americas. So we're in the region. And with the positivity rate for influenza of 28.2. So if we test 28 persons with an influenza-like illness, about 28.2 are 28 of them are positive for influenza. And of that, influenza A, H3N2 predominates. And to a lesser in some areas of the region, influenza A, H1 pandemic of 2009 predominates. So that's what's happening in the region. And before we go a little deeper in what's happening in Jamaica, within the respiratory surveillance system in Jamaica, there are 4 components. So we have 78 sentinel sites, which we get weekly information on for influenza-like illnesses. Then we have 6 hospitals, sentinel sites, which we get severe acute respiratory infection information from week in, week out. For the other component is a class 1 disease notification system. Among respiratory, only acute respiratory, only COVID-19 is a class 1 disease currently. And then there is viral identification, which is done through the National Influenza Center, which is located at the Department of Microbiology at the University of the West Indies. So this shows our SARI and ILI sites in Jamaica. So all parishes have ILI sites, and all the regional hospital and national hospitals are SARI sites. We are also part of the global network, and We would send epidemiological data to PAHO WHO, as well as we send information on what has been detected from the National Influenza Center. We also work with WHO collaborating site, which we would send for quality control, as well as to be part of what comes out in the vaccine components. And we do send reports to CARFA as well as a regional agency. So we look at 3 age group when we look at influenza. So in reading these charts, and this will be similar for the 3 age groups that we will look at, the yellow line represent the seasonal threshold. That means we're in flu season when we go above the line. The green line represents the alert threshold, and then the blue line is epidemic threshold. So this chart shows what happened last year and what's happening this year in the under 5. So we breached the seasonal line just once so far for this season, which is usually the latter part of 1 year into say March, April, or the following year. But what we note for this time is that we are a bit higher. The activity level is a little higher, well, could be double at some weeks than what we saw last year. So we are seeing more than last year. We appear to be in season, but we are not at alert or outbreak levels. For the 5 to 59-year age group, so we would have gone over the seasonal line twice. Late last year we didn't, and approach alert level in some instance, in one instance. So same thing, we're seasonal. When we look at the 60 years and older, we went above the seasonal line, but not at alert or epidemic levels. So, and we are about where we were last year. Some weeks less and some weeks more. However, we need to drill down at the parish levels. So when we drill down to the parishes, there are parishes that are sticking out. For under 5, we have St. Catherine, KSA, Hanover, that seem to have quite a higher activity than usual. So KSA is there again for the 5 to 59, Hanover, Westmoreland, St. Elizabeth. And then for the 60 years and older, KSA and Westmoreland. With respect to SARI admission, this is when we look at numbers, so with absolute numbers and look at where we usually are at. So we are greater than we were last year. And we approach alert level 2 weeks and reach alert level 1 week. With respect to when we look at the percentage, so what percent of the hospital admissions are for sorry. And this we are running at about 1.5, but in last week 4, we went down. So this is what we are seeing for SARI. So those are the sentinel surveillance for influenza-like illness and SARI. For COVID-19, which is our class 1 disease, for the last few weeks, we have not identified any COVID-19. Last 4 weeks, no COVID-19 has been identified, whether through the regular surveillance, through the NIC, or through the private and public laboratories. So what are the viruses circulating? So if we look week on week, this is from last year. So last year, early in the year, this time, influenza A, H1N1 pandemic strain of 09 was predominating. Then when we get into May, June, we have SARS-CoV-2, and then we went in that time with RSV and influenza A, H3N2 to the latter part. Sometimes it's not as useful to look at just week on week. So what okay, we'll come back to that. Just a more extended view. So this is what we would have shared so far. This is what our report looks like in the bulletin, influenza bulletin from PAHO WHO. And to extend the weekly to 2018, if you note, we were not identifying, once we start having COVID and had the different protocols, we did not identify influenza because of what we had implemented. For the latter part of 2020, we had discontinued testing for a few months. So, but that does not explain when we restarted in the latter part of 2020, and there were no cases of influenza identified. On the right, we've seen the percent positivity that is being observed. And so we are in the 40% based on data. We went up as much as 40% and we are decreasing. So if you recall, the regional positivity was about 28%. At that time, we were about similar, and it went up a bit. All right. What we do too is look at a 4-weekly average. So we do a running average of what we are picking up. And so if we note the influenza A, H1N1 pandemic 09 in the early part, COVID in the May, June, which is what we are seeing evolving, that COVID season is around May, June. And then we go into the influenza season. And over the 4-week period, influenza A, H3N2 predominates. And since the start of the year, we are getting some amount of RSV start to increase again. And then if we look at the percentage, it's just a little clearer. So in summary, what we have the influenza-like illness were below epidemic threshold. SARI wasn't seasonal, average SARI hospitalization in Epi week 3 at 0.96% and Epi week 4, 0.72%. KPH was missing out of that Epi week. The respiratory viruses identified in the 4-week period, Epi week 1 to 4, influenza A, H3N2 at 90%, influenza A, H1N1, pandemic 09 at 5%, RSV at 5%. We did not identify any SARS-CoV-2 or influenza B. For this season, we don't have any reported SARI deaths. So recommendation is that we vaccinate and we follow what we call our COVID protocols, but it's really the influenza protocols. And we are in influenza season, which is a bit more active than it was last year. And influenza A, H3N2 is predominating. So there are resources that you can look at. So we do put out a weekly bulletin from the National Epidemiology Branch, National Surveillance Unit. And we also, there is online the PAHO WHO bulletin, which you can look at to see what's happening. So that's it. Thank you very much.
Dr. Webster-Carr, thank you very, very much for those statistics and for your presentation, which just showed us how you go ahead, how you map out and see what is important, what is not as significant, and the seasons, when we see the RSV, when we see the influenza, when we see the COVID in play. Many of us here, of course, are not. This might be the first time we're becoming aware of that rhythm. I'd like to ask members here who have questions, please fill our Q&A. It's not being used. Put the questions you have in mind based on what Dr. Webster-Carr has just shared with us in the Q&A, so that put them now so that you don't forget, because as you get to the next presenter, you are going to have other questions you want to answer. One quick question for you, Dr. Webster-Carr, would be the fact that things seem so bad, this flu seems so predominant. It seems, is it fair to say, it seems that it is overall running at a little higher level, generally speaking, than it was before, 40% as opposed to whatever before, increase over the norm at some times, and that perhaps the reason why it is more notable is because of the symptomatology and in the presentation, and how the fact that it's a quote, bad flu. Let me hear that quickly before we move on, but that's just a quick response for now. Thank you. Dr. Carr? Dr. Webster-Carr?
Yes, I was trying to figure out how to respond. So I think we haven't had a flu season like this in a little while, so it seems more than usual. As was demonstrated, it was twice as many at some weeks than before, So I think that's the reason why it feels that way. But based on the numbers, I can't say, and it is, I can't say any more than that.
Okay, because well, I had some, with my a relative being ill, went to the pediatric the hospital, and they told me they were actually seeing quite a few babies with a lot of pneumonia, bad pneumonias, even lobar pneumonias. That was concerning. So they had a lot of admissions, and anyway, we will come to that in our Q&A. And I just want to thank you so much again for clarifying the statistics with regards this flu virus. Thank you. And it is now my pleasure to introduce, thank you, Dr. Webster-Carr. But it's my pleasure now to introduce to you our emeritus Dr. Professor Celia D.C. Christie. She is someone that we all know very, very well. The medical people know because she is someone who has established her worth and her value. And when she comes to us, she comes to us like a speeding bullet or like a gloved, something with a nice glove on it, but there's something tough in there. It's going to stone. Yeah, there's a lot there that we're going to have to take. We're going to have to take. She comes to us with a wealth of knowledge, about her, generally speaking too, and definitely about her pediatrics, her babies, her children, her adolescents. She is so full of qualifications. I don't know where to start. Dr. Professor Emeritus Christie, I am going to just quickly say a mouthful and then give over to you because Celia Christie, CD, MBBS, DM, MPH, FAAP, FIDSA, FRCP, Edinburgh, is Professor of Pediatrics, Infectious Diseases, Epidemiology, and Public Health at the University of the West Indies, UWI, consultant pediatrician at the University Hospital of the West Indies, Jamaica, since 1999, and Professor Emeritus since 2022. She's a graduate of the University of the West Indies, undergrad, DM, and she did her MPH at Johns Hopkins University and completed pediatric infectious diseases and epidemiology doctoral fellowships at Yale University School of Medicine. She's done so much. Her area of research interest included clinical trials of vaccines and epidemics of emerging infectious diseases. She has done a lot of work and a lot of research in many areas on our babies and our children. So, she has many honors and awards, including the Elizabeth Glaser Pediatric AIDS Foundation International Leadership Award, Excellence for Sciences, and all sorts of stuff. So I am just going to tell you that it is impossible. It will take a day and a half to tell you about the glories and the gifts that Professor Dr. Celia Emeritus Christie has given the Jamaican population and the West Indies and the world. So over to you, Dr. Christie. You are, hear me, doctor, keep on not saying Professor Emeritus Christie, who will be speaking with us now on the influenza A H3N2 K9 outbreak, managing its effect in children and adolescents. So it's over to you, Professor, and listen carefully. You will never hear it told better. So listen carefully.
Good night, colleagues. It is indeed my pleasure, my privilege, and my honor to speak to you this afternoon or this evening on the influenza AH3N2 subclade K outbreak, which is now ongoing in several parts of the world, and its management and impact on children and adolescents. I thank Dr. Ononuju for inviting me, and also the organizers. I also thank Dr. Arna Morgan for her very precious introduction. So, what's different for children this flu season, and why are we here? The influenza AH3N2 virus, the subclade K, has seen 7 new mutations, and this is what is thought to be causing a widespread, early, and intense epidemic in Europe, which started some 3 to 4 weeks earlier than we would normally expect for the influenza season. And it's also causing a similar outbreak in North America. This subclade K was identified by the CDC in August 2025, but this was after the viruses for the 2025-2026 influenza vaccine were already selected from February 2025. This is really called antigenic drift, which we heard from medical school can cause mutations with evolution of different hemagglutinin genes in the influenza viruses, and in this particular one, in the influenza AH3N2 spreading viruses. These are therefore vaccine evasive strains. The influenza AH3N2 subclade K is not accounted for in this year's flu vaccine. Influenza AH3N2K probably represents some 92% of current cases in the USA's flu season, and influenza AH3N2 is now being reported in Jamaica, and certainly Professor Anzinger has reported that it is present in the UHWI and the UWI wastewater. This is the sewage from both areas of the university campus. It's also the most prominent virus now being reported from children and adults who are presenting for care at the university hospital. We're also seeing a tail end, maybe, of the RSV upsurge. In Europe, children aged 5 to 14 years of age are thought to be the main drivers of the current epidemic. The highest incidence and hospitalizations are in children of all ages, the preschoolers, the school-age children, and adolescents, as being reported by the CDC in the United States. The Europeans are saying that influenza vaccines are offering moderate protection against severe disease in Europe, but this is preliminary data. The United States, through the CDC, is saying that the majority of children who died never received the influenza vaccine. The illness is heralded by fever, vomiting, fatigue, and headache in children in Europe, and dehydration there is prominent. It is thought that the clinical course is longer, it's more complicated, and it's associated with the usual complications that are peculiar to children who have influenza. The question is, what's happening with co-pathogens? What's happening with secondary bacterial infections and other pathogens? And I think we also need to be cognizant of the fact that there was a bird flu epidemic in animals, in birds, in Cayman recently, and this was important for Jamaica. I'll say a little bit more about that in a while. And so far, there were 71 human cases in USA. Let me say that I don't think we have any bird flu cases in humans in Jamaica, but I think we need to pay attention. So what is the CDC saying as it relates to pediatrics, as it relates to their surveillance systems? And this is the data as it was presented on the 31st of January, 2026, and as published. Seasonal influenza activity is predominant with influenza AH3N2. This is what is predominating, as shown by the peaks in both charts shown here. Of 822 influenza AH3N2 viruses, which were collected since September 28, 2025, that underwent additional genetic analysis at the CDC, 91.5% were reported to belong to the subclade K. The weekly influenza-associated hospitalization rate overall from the FluServe Net program peaked during week 52 of 2025. That goes up to the end of December. And the rate was 12.8 per 100,000 population. And this is the highest peak since 2010, the 2010-2011 season. And if my math tells me correctly, that would be what now? Some 15 years ago. The CDC reports that children who are younger than 18 years of age have the highest peak of weekly hospitalizations rates that have been observed, and the hospitalization rates are highest among the infants who are less than 1 year of age, to the tune of 105.6 per 100,000 and incidents, followed by children in the aged 1 to 4 years of age. That is 56.4 per 100,000 population. So far, they have some 60 reported influenza-associated pediatric deaths. This is underreported. Deaths usually take a little time to come in, but among these children who were eligible for influenza vaccination and with known vaccination status, 90% of the reported pediatric deaths in this season occurred in children who were not fully vaccinated against influenza. Additionally, the CDC reports that the pediatric age group is classified as having the highest severity of illness, while both the adult and older adult, meaning the elderly, are classified as having disease of moderate severity. So this is the cold and flu season, and we have to first think about how we're going to approach taking care of children in hospitals, in clinics, and so on, and in doctors' offices, by figuring out clinically what do we think is happening here. Now, for influenza, we tend to look at infants and young children in one group, and we look at influenza in older children. So what are the symptoms that we are seeing now? In the past, we would see fever, headache, chills and rigors, and sore throat, and the fever would be very high and of sudden onset. And these are the initial presenting signs and symptoms. In the current outbreak, as we said, in Europe, they are seeing fever, which is of sudden onset and very high, with vomiting, fatigue, and headache, which is showing up in the children early on. Fever, vomiting, fatigue, and headache. And I stress that because if you're having vomiting, and if later on you have diarrhea with it, along with losing so much of your insensible water loss with the high fevers, you're going to become dehydrated. And dehydration in children, even in older children, can be very, very significant. And we need to deal with this immediately. The children will also present with influenza with chills and rigors, sore throat, a scratchy throat or pharyngitis, a stuffy runny nose, a cough which becomes more severe, conjunctival itching and redness, severe myalgia and muscle aches, nausea, which accompanies the vomiting and the abdominal pain, and later on the diarrhea, and the fatigue, as we mentioned before, loss of appetite. It is said that these children are also having a more prolonged course than what we were accustomed to in years gone by. It's still early days yet. In the young children, they're also presenting with vomiting, but they're also presenting with influenza with a non-specific sepsis-like picture which includes irritability, poor feeding, and apnea. Later on, they can have like croup or lower LTB, laryngotracheal bronchitis. They can present with a pertussis-like illness. They can have pneumonia. We'll talk more about the pneumonia in a while. In addition, there are other cold and viruses and other enteroviruses which can have some of the similar symptoms. But of course, these are much, much milder. There is fever, which will be low grade or absent, runny nose and sneezing. And the cough in these patients tend to be mild and hacking. When there are enteroviruses, they will present with skin rash and mouth blisters. They'll also have body aches and muscle aches. Some patients can be managed at home. If they have their doctor online, they could call, and especially now that the hospitals and clinics are full. Some patients that could be managed at home could have fever, cough, fatigue, and runny nose. Improvement usually is noted with fluids, rest, and non-aspirin pain relievers. There is no need for a doctor's visit or a hospital emergency room visit if you have a doctor on the line who could help you you could call in and they could guide you, especially if there is no underlying illness and if recovery is happening within, say, 3 to 5 days, 3 to 5 days, they're getting better. However, I'm sure the doctor's offices and the clinics and the emergency rooms are now flooded with doctor's visits for non-urgent symptoms, which are recommended for infants who are younger than 3 months of age, who have fever, even though the fever may be a lower fever than what the older children would be presenting with, 103, 105. Children with sickle cell disease in our setting must go to a doctor. If the fever is lasting more than 5 days, they need to go to a doctor. If there's a new fever or the fever went away and there's now a secondary fever, that's another sign to go seek medical attention, because this might represent a complication or a secondary infection. If there's a poor response to the medications you're using at home, which is Panadol and other pain and fever reducing agents, fluids and rest, then you need to go to the doctor. Definitely for vomiting. Any child who is vomiting, especially in this outbreak, which seems to be associated with repetitive vomiting. And of course, if you have dehydration, you must go to your doctor. Some patients may wheeze, some patients may have severe muscle pain. There's weakness for a wide variety of reasons, and there's back pain for a wide variety of reasons as well. And of course, if there are unusual symptoms like hematuria, you really need to visit your doctor. When the patient goes to the doctor, the clinic, the private doctor, the urgent care, essentially, there are sometimes flags when you should probably be thinking of referring for hospital admission. If the patient has ongoing respiratory distress with a persistent cough, we should refer. If there is inconsolable irritability and neck stiffness, now we're dealing with the possibility of meningitis, please refer. If there's confusion, as you know, that can be associated with many issues, you should refer. Vomiting and diarrhea, especially when associated with the diarrhea, with dehydration, which is now going on to become moderate or severe. I know in urgent care and so on, we'll start we'll do the IV fluids and so on, but sometimes the children do not recover, and there's electrolyte imbalance and so on, and there is ongoing losses. In those cases, we should also refer for hospital admission. Influenza sometimes also presents not only as influenza, but it also presents with other viral co-pathogens. So you may be picking up influenza, but there's also RSV there, parainfluenza, the human metapneumoviruses, the rhinoviruses, the enteroviruses, the adenoviruses. And this is causing a complex presentation which may not necessarily be evident to us in the outpatient setting. Definitely for complications, we would want to refer or think about referring for a hospital admission. They present with very, very high fever, so they're going to have febrile seizures. There's a variety of neurological presentations that they can present with. These may include severe encephalopathy, encephalitis, and again, the febrile seizures. Myocarditis is not good. When patients present with myocarditis, they can die. Myositis is also evident, can also be evident when the CPK is very high. And influenza B is usually associated with this. Acute otitis media is a complication. The influenza can stimulate an asthmatic attack and even status asthmaticus. Acute chest syndrome is something we always need to think about in the sicklers. And if you have a sickler, we need to think about that. And then again, there are the pneumonias. The pneumonias can be viral due to the influenza, and some patients may even have a hemorrhagic viral pneumonia. Can you imagine that? And then others may have the secondary bacterial pneumonia and bacterial co-infections. And these can present with their toxin-mediated manifestations as well. And the pathogens we usually tend to think about are Streptococcus pneumoniae, the group A Streptococcus, the Staphylococcus aureus, and remember MRSA is sometimes present in the community, so that could also be playing a part. Mycoplasma pneumoniae, and even complicated pneumonias and sepsis we need to think about. Now, there are some underlying comorbidities that we need to think about in children, which will precipitate hospitalization and complications. And these patients should be targeted for antivirals and for immunizations, influenza immunizations. These high-risk categories include children, especially those who are aged 2 to 6 years of age, preterm infants, children with chronic pulmonary disease like asthma, cardiovascular disease, kidney disease of all kinds, chronic kidney disease, chronic liver disease, metabolic disorders, hematologic disorders like sickle cell disease and other hemoglobinopathies, and of course, a wide variety of neurological disorders, as shown here. Every year, we have children who come into the hospital with underlying neurological illnesses we have to pay special attention to because, they are at risk for serious disease. And if not managed properly, they could die. And they are listed here. Immune suppressed patients, including patients with HIV, should also be included in this list. So how do we diagnose influenza? We go through the clinical symptoms. As we said before, remember the UWI grads, we are all excellent clinicians and we know how to do anything that has to do with clinical medicine. And usually you'd have, or maybe you won't, have a history of previous exposure within the last 2 to 3 days, most times. But children can also transmit or can also transmit infection in an asymptomatic setting. So the child may be asymptomatic and pass influenza on to this particular index case, but you can't really find to say who was the contact. There are several rapid diagnostic tests that are circulating out there. They look at the antigen, and you can either look for the influenza A and B antigen as a single test, or you can have multiplex diagnostic tests, which not only find influenza A and B, but they also look for SARS-CoV-2 and respiratory syncytial virus. The challenge, though, is that the sensitivity and specificity of these tests is rather low. Once the patients come to us in the hospital, we use the molecular diagnostic tests, the RT-PCR. Once influenza we know is circulating in the community, this is what we do. It's an expensive test, but our hospitalized patients should be tested with what we call this nucleic amplification test. And this, the sensitivity and specificity, when done properly, will approach 100%. I still think we should ask about exposure. When our patients come to us, ask them if they have been exposed to sick or dead animals, including birds, poultry, cows, because in our setting, we need to evaluate and to test for avian or bird influenza. And that is influenza AH5N1, which now is related to the antigenic shift. We know that the avian bird flu outbreak happened in Grand Cayman just a few weeks ago. And the particular farm where these animals were was actually closed down, and the various animals were culled. These includes chickens, turkeys, quail, farmed ducks, wild whistling ducks, and geese. And I think this is important for us, not because I'm bringing or wishing for avian bird flu, but we need to ask the question. In the United States, the 71st case of bird flu was identified and notified to the WHO on the 15th of November, just gone. And I saw in the press about 2 days ago where they are now experiencing a bird flu outbreak in birds somewhere in New York. Several birds died, flocks of birds died. In the United States, there have been 2 reported deaths for humans as it relates to avian bird flu. Just to say is that there are no known cases of human-to-human transmission of bird flu that have ever been identified. Let's now turn to treatment and how should we treat patients who have influenza. And what is universally recommended is antiviral treatment for children with suspected or confirmed influenza. Definitely for everyone who is hospitalized. Definitely for everyone who has underlying or progressive disease, who has a high risk of going on to develop severe influenza complications. And we should consider treating some children in the outpatient setting. We should commence these antivirals ideally within 48 hours of symptom onset in outpatients, but it is still beneficial in hospitalized patients, regardless of their prior duration of illness. These antivirals can also be administered to children with household contact who are less than 6 months of age, or those who have a high risk of an underlying condition that will predispose them to influenza. The antiviral medications that are talked about in America, certainly by the CDC and the AAP, that are recommended for children, are really 4. And I think in Europe they have 1 or 2 additional ones. The one that we would recommend, and the one that we have, and I'm not even sure if we have any now in the island because it's in such great demand, is the neuraminidase inhibitor called oseltamivir, or what we call Tamiflu. It has side effects of nausea and vomiting, so I guess that would be would sort of confuse the influenza presentation in and of itself. And the Japanese have reported that the patients who take Tamiflu have a higher risk for self-injury and delirium. But that has not been confirmed in this part of the world. There's also zanamivir and peramivir. And then there is baloxavir which is a polymerase acidic protein endonuclease inhibitor. But those 3 drugs, as far as I know, are not available in Jamaica. Oseltamivir or Tamiflu can also be given for antiviral chemoprophylaxis in patients who are not immunized, who have a high risk of complications, and they cannot mount an immune response should they be at risk of exposure for influenza. So what are the supportive measures? We use fever and non-aspirin pain relievers. We know the reason for that because of the risk of Reye syndrome with aspirin. We also have several other measures that we could use to reduce nasal congestion, normal saline nose drops, a humidifier at home. There are several over-the-counter cough medicines, whether suppressants or expectorants or multi-symptom products, of which there is a wide variety. Throat lozenges are sometimes used in the older patients to soothe throat pain, but I wouldn't give it to too many of the younger children just in case they may choke, and before you know it, you have a problem on your hand. The big problem in this outbreak, I think, is the risk of dehydration because, as we heard, vomiting is a prominent feature of this outbreak. Oral and IV fluids are given to children depending on the level of dehydration. And I just put up a little chart here with regards to mild dehydration, the clinical features, patients who are less than 5% dehydrated. Moderate dehydration, those are 6 to 9%. And severe dehydration, those who are more than 10% dehydrated. And we know all of these signs and symptoms. Dehydration can also be isotonic, hypotonic, or hypertonic based on the sodium concentration in the blood serum. And treatment, as we know, is for mild dehydration, we give oral fluids as shown. Moderate dehydration, we give oral fluids, and if the child is vomiting, as they probably will, you can pass a nasogastric tube, but it's probably easier than passing the nasogastric tube just to start the IV, because the vomiting will probably continue for a while. And as you know, children, especially young children, lose water very, very quickly and become severely dehydrated very quickly. IV fluids are given, and we give normal saline bolus, repeat it if needed, and remember, in the meantime, we look at CBC and electrolytes and correct as appropriate. This is a history for one of the patients on the ward, and this one has, this child is a 5-year-old with sickle cell disease, and his test came back influenza A positive. He presented with fever, URTI symptoms, chest pain over a 2 to 4 day period. He had no shortness of breath or wheezing or no hypoxia on presentation. He was, however, quite ill-looking with markedly reduced breath sounds, and his chest X-ray is shown on the side here, and you see there's a whiteout on the left side of the chest. In general, for patients who are hospitalized during the influenza season who have pulmonary consolidation, we say they have pneumonia. In the sicklers, it may be acute chest, but in everybody else, it's probably a pneumonia. And for those at basic, we do a CBC, and we're looking for a high white cell count if they have a bacterial infection, as you know. We're looking for blood cultures. Sometimes the blood culture may come back positive for Streptococcus pneumoniae, even though very rarely. We'll send throat swabs for bacteria and viruses, but this time now we're doing PCR for viruses. And we also do the ASTO titer, recognizing that the antistreptolysing O titer, if it's due to group A stress, it's not going to rise for another 2 to 3 weeks from the time of presentation, if that is the secondary bacterial infection that's causing the pneumonia. Because they are hospitalized, we offer everybody Tamiflu, or we should offer everybody Tamiflu, oseltamivir during the flu season. For antibiotics, I usually like to start with azithromycin and augmentin. Azithromycin because you're worried about your mycoplasma and other atypical pathogens. And then augmenting, of course, will cover your strep pneumo and your group A strep, and even your Staph aureus to begin with. Sometimes we go straight to ceftriaxone because the private doctor would have already tried these outside, and now the child is here. And sometimes we may even go a step further up and start vancomycin for drug-resistant strains. In addition, we also give oxygen, fluids, the pain and fever reducers, and chest physiotherapy. In sicklers, we give blood. We make sure we start off with blood for group and cross-match, because we may need to give a simple top-up transfusion or an exchange transfusion. And sometimes, unfortunately, we need to go to ICU management. Some of the patients have a complicated pneumonia, and this is not a good thing. Not a good thing. They have severe lobar pneumonia. Most times we know it's due to Streptococcus pneumoniae, and then they go on to have pleural effusions, and from pleural effusions to pleural empyemas, pus, and sometimes there are abscesses. If they come to us early, then we could do a chest tube, put in a chest tube, and we could either do put in urokinase or streptokinase with the help of the cardiothoracic team to break up the pleural adhesions, because again, the parietal pleura and the visceral pleura get stuck together because there's a lot of pus, and it organizes very, very quickly. If you caught it late, then sometimes you have to do a pleural decortication, and of course, you have to give parenteral antibiotics, and by now you should be considering drug-resistant Streptococcus pneumoniae and giving ceftriaxone and vancomycin. The problem is that this illness can cause restrictive respiratory failure and lung disease because of these loculated fluid collections. You have the trapped lung syndrome, you have necrotizing pneumonias and abscesses, bronchopleural fistulae, and death, unfortunately, without surgical drainage and prolonged antibiotic therapy for weeks. And here we have some information here on a child with a chest x-ray, which is showing opacification, complete opacification of the left hemithorax with tracheal and mediastinal shift to the right. And then there's an axial chest CT with contrast, which shows a large pleural fluid collection and almost complete left lung atelectasis, right? So this is just not good. I also thought I should speak a little bit about some of the more terrible streptococcus complications that we can see after influenza. We can have group A strep pharyngitis and tonsillopharyngitis. These patients will not only present with a sore throat, but they will also have tender anterior cervical adenopathy, and some of them also have petechiae and the strawberry tongue, a strawberry tongue. You'll see here from the pictures the organism that is in chains, and you'll also see here from the pictures a patient with a peritonsillar or retropharyngeal abscesses, and sometimes they also go on to have suppurative cervical adenitis, sinusitis, and otitis media. The scarlet fever, as I said before, will present with the petechiae and the strawberry tongue, along with pharyngitis. They will also have this erythematous sandpaper rash from the group A strep exotoxins. The group A strep can also present with infections everywhere else in the rest of the body, including the skin, the bloodstream, the lungs, endocarditis, pericarditis, septic arthritis, necrotizing fasciitis. That is awful. It eats away all of the skin and subcutaneous tissue, muscle, and so on. And this is something that you need to intervene in within 24, 48 hours. You know, sometimes you have to do amputation of limbs to control the spread of infection. There's also purpura fulminans, as shown here, osteomyelitis, myositis, and mastoiditis. The penicillin is the best antibiotic for streptococcus infections, which will reduce suppurative infections. And again, we need to remember the long-term complications of acute post-strep glomerulonephritis and acute rheumatic fever. There is also the toxin-mediated manifestations, streptococcal toxic shock syndrome, where these patients will have the group A strep isolated from the throat and can also be isolated from other non-sterile, previously not supposed to be sterile sites like blood, CSF, peritoneal fluid, joint, pleural fluid, pericardial fluid. And they will present with hypotension and shock with more than 2 organ systems involved as shown here. And they can also go on to have soft tissue necrosis, necrotizing myositis, and gangrene. How do we manage this? We give fluids, we try to maintain a cardiac filling pressure and prevent end organ damage. We need to anticipate multi-organ failure. We need to kill the group A streptococcus with a bacterial cell wall inhibitor, preferably penicillin or ceftriaxone. We also need to use an enzyme toxin or decrease the enzyme toxin and cytokine production with a protein synthesis inhibitor, which would be like clindamycin. So this is in one of the strange situations where you're using 2 antibiotics which work in different ways to kill the same pathogen. So you're using clinda and you're using penicillin. And intravenous immune gamma globulin is also recommended. The management of the necrotizing fasciitis, we have to call in our surgeons immediately, and essentially they need to resect the necrotic tissue, repeat until they get a clean margin, and sometimes, as I said before, they may need to go and amputate. No. Respiratory syncytial virus, we are, I think, coming to the end of the season, but who knows? Do we test for RSV in everybody? And so I thought I should speak about RSV in this setting as well. RSV, as we know, has a global incidence of over 33 million people, children who are 5 years of age, less than 5 years of age. And 1 to 5% of these will require hospital admission. And unfortunately, up to 200,000 will die from this disease. Everybody is infected with the respiratory syncytial virus by the time they are 2 years of age, with the presentations of respiratory presentations of upper respiratory tract infections, bronchiolitis, and lower respiratory tract infections in 25% of cases. They'll have rhinitis, cough, tachypnea, wheezing, crackles, intercostal and subcostal retractions, grunting, nasal flaring, and they may or they may not have fever. There is also lethargy, irritability, poor feeding, and minimal respiratory effort, and even apnea in preterm infants. The risks are shown, they are the same as the risks for influenza. How is it treated? Hydration, fever reducers, normal saline nose drops, remembering now that children are obligate nasal breathers, and if their nose is blocked, they can't feed, so we need to be sure that we clear the nostrils to allow them to be able to breathe. There's also oxygen, which can be given by nasal CPAP in some cases, and we offer bronchodilators, even though it's not generally uniformly recommended. There's also palivizumab, which is a humanized monoclonal antibody, which is given monthly in high-risk children, and I know that it is offered here, certainly in the babies from the NICU who are at high risk for RSV disease at a cost. The vaccine is also offered to pregnant women in the 3rd trimester. So we prevent influenza with the use of influenza vaccines. And this vaccine is recommended for all children as soon as possible from early October. It's a trivalent vaccine, is the one that we're using here in Jamaica from GC Biopharma. It's WHO pre-qualified, it's PAHO approved for us, and in fact for the region. It's an inactivated vaccine, and it is released in multi-dose vials. This vaccine uses an egg-based manufacturing process. We give it to patients who are older than 6 months of age, who do not have medical contraindications. In other words, if you have an egg allergy or if you have anaphylaxis, we wouldn't offer it to you. It's given in 2 doses, 1 month apart, if it is being given for the first time when being offered to children who are aged 6 months to 8 years. If a child is older than 8 years old and they have received the vaccine before, then they would get just one dose each year. The vaccine is reconfigured every year, as I said before, early on by about February or March, and then it is made up. And you'll see here, if you compare the egg-based vaccine, which is what we're talking about, the trivalent vaccine, for the 2024-25 season to the 2025-26 season, you'll see that it changed from A, Thailand to A, Croatia. However, the influenza A, H1N1, and the influenza B, Victoria lineage, did not change between those 2 periods. There are many measures that we can use in the public sector and in your offices and in your hospital clinics, and even on the wards to improve childhood influenza vaccines, and especially now that we're in this serious outbreak. It is recommended that we should review influenza vaccination status at all visits and we should be prepared to vaccinate at all visits. I know all of our hospitals have a public health nurse, and we have tons of public health clinics all over Jamaica. And Jamaica, certainly before Miss Melissa came by, was one of the top countries in the world, and I felt so good when I looked at that WHO data for receiving the primary childhood immunization vaccines. The uptake was excellent and outstanding. So we would want to try to do what we can to improve our uptake of childhood influenza vaccines. Hopefully they are available. Vaccinate at all types of visits, whether in hospital or in clinic, and give the appropriate messaging, whether by speaking to the parents or by using flyers, and and in your offices, I'm sure you can do a lot more than probably we can do in our hospital settings. I can't close unless we speak about the pneumococcal vaccine, because as you saw and as you heard, and you heard Dr. Arna saying that, my goodness, how many children she had referred and how many children she knows of who have lobar pneumonias. The pneumococcus is the secondary bacterial pathogen that is going to complicate influenza. And there are vaccines available for that. There is the conjugate vaccine, pneumococcal vaccine, which is 13 valency, and it's available for infants and children aged 2 to 59 months. We give it at 2, 4, 6, and 12 to 15 months with catch-up at 59 months. I think the Ministry of Health has a plan to roll out the conjugate pneumococcal vaccine to the annual birth cohort. I don't know if they're still going to do it, because I know Karen and company are stressed as it relates to the healthcare system and how it was battered by Hurricane Melissa. I think if they do it, they're probably going to use the 7-valency pneumococcal vaccine, but that's okay. And then there's a polysaccharide vaccine, which is a 23-valency pneumococcal vaccine for 6 patients who are aged 6 to 18 years who didn't receive the vaccine and are at risk for invasive pneumococcal infections, and all others who also received it. We need to prevent transmission of influenza. This is a highly transmissible strain, and the Europeans are saying that this is what is driving the epidemic right across Europe. So we need to be sure that we improve, ways to prevent transmission. And then we practice standard precautions in the hospital and droplet precautions if the patients are hospitalized. Standard precautions everywhere and droplet precautions if hospitalized. Hand washing is important for the children and their carers. Masks and cough etiquette is also important. One should really stay at home for duration of illness. Now that is very difficult because I suppose if everybody stayed at home, who would be around to drive the economy and who would be around to take care of patients in hospitals and so on? But what can I say? You can be infectious with this. Children are usually infectious for about 3 to 4 days, but this can be extended to up to 7 days and maybe who knows more with this particular virus. We should try to limit contact with others, and we should try to clean environmental surfaces that are often touched. So, in conclusion, this influenza season is caused primarily by the influenza A H3N2 virus in the United States, with the newly emerging case of clade in Europe, in the United States, where they say it represents 92% of strains that were tested as of the end of December. And this is also spreading in other countries. The important thing is that it is not accounted for in this year's seasonal flu vaccine. Influenza A H3N2 is also predominating in Jamaica and Europe, and RSV is likely still circulating, even though we may be on the back end of the RSV outbreak. The influenza epidemic toll on children is thought to be significant. The virus is highly transmissible, and children are the main drivers of the epidemic in Europe. The highest incidence and hospitalizations are in children of all ages, according to the epidemic being reported in the United States. Severe illness is occurring in children as compared to adults and the elderly who are having disease of moderate severity, according to the reports from the United States. This particular illness is heralded by high fever going up to 103, 105, vomiting, fatigue, and headache in Europe in the children. It is thought to have a longer course. It is thought to have complications that are peculiar to children, especially dehydration and pneumonias. The majority of the children who died in the United States, up to, as reports from the end of December, they did not receive the influenza vaccine. And it is thought that perhaps if they got the vaccine, they might have had some protection, as early indications are that the vaccine is somewhat protective in Europe. So the diagnosis, treatment, and prevention of influenza in infants, children, and adolescents in this year's season remains the same as in previous seasons. The management has not changed. It's just that we need to be a little bit more vigilant in taking care of the children who are dehydrated and taking care of those who have pneumonias and trying to diagnose as many as possible and do what we need to do. Still, the influenza vaccine is still being recommended that it be given, and Tamiflu or oseltamivir is also highly recommended to ameliorate the disease course and to try to prevent deaths in children. Thank you so very much for asking me again to speak, and That's my last slide. Thank you.
And we thank you, Professor Christie, for such a complete presentation from the width across the world to the specificity of what we're seeing here, and then to what can happen, what we can see alongside it, and then again to how to treat it, how to recognize its symptoms and treatments. It's very, very inclusive and very, very much appreciated by us here this evening. Some things that, this whole idea of vaccination, it's been such a problem since the COVID, and is part of the reason, I'm sure, why it just seems so bad everywhere. So, I mean, here's a plug for vaccination again. We need to get on board and we need to find a way to make this work. That's on the ministry, that's on us GPs and all the physicians, and that's on the people who are lay people listening to us this evening. We need to get on board with vaccination. The other things that you had said, so distressing, this evasive strains, the ones that this genetic drift. This is going to be the trend, because it makes vaccination then difficult. So again, I'm asking everybody to please put your questions in the Q&A. We'll have a little Q&A session. I know people tend to drop questions in the chat, but it's going to be hard. Although I'm hoping our Mr. Sam Heron is picking up on whatever is happening in the chat for us, so that we can have a quick and vibrant Q&A later on. Thank you so much, Professor Christie.
Thank you so much, Dr. Morgan, and thank you so much to all the people who are sending you congratulations and saying thanks. I appreciate your comment. I appreciate that. Thank you. Thank you. Thank you so much. Thank you.
So we're back on board with us at the end for the Q&A. Thank you.
Yes, ma'am. Thank you.
Okay, so over now to guess who? Mr. Samuel Heron. Now, Sam, we have a couple of questions for you. We know you're going to. Sam is one of the sponsors for our this webinar. This platform is his, and he is someone who has been our friend and worked alongside us with these webinars for many, many years now, especially with the Caribbean College of Family Physicians. So now Sam has his own little sponsorship slot here. But Sam, could you please bring us a little bit on board? Tell us how many people that we have between this platform and YouTube. And we're open to hearing more from Allgate. Thank you, Sam. Over to you. Your voice is very familiar to everybody. We know you well.
Hi, Doc. Thank you so much. It's really an honor for us to join you and to support you in this timely webinar. I think the registration number speaks clearly to just how important and timely this webinar and this session and this learning is, as the physicians continue to not just re-educate themselves, but provide exceptional care to our country, Jamaica. Overwhelming amount of registrations, almost 2,000 persons. We have about 500 with us on Zoom, and then we have about another 510 on YouTube. Now, we understand that some persons probably heading home, they probably lost connection, etc. But we thank you guys so much for joining. So again, just wonderful, wonderful presentation so far. Don't want to keep you too long. I do understand it is Friday the 13th, so we don't want you to be out too late on Friday the 13th. But again, we thank the CCFP for allowing Allgate Solutions to support. 1 second. Yeah, I think we have a little video here just to show you tell you some things about what we do, and then I'll hand back over to Dr. Arna. Thank you so much. Back to you, Dr. Arna.
Sam, you really have been brief, and you remember this is an opportunity for you to just show us here your face. Let people have a quick look at Sam Heron. One quick look, Sam. Put yourself on. Let's see your face. Just this moment.
No, I'd love to, but I really can't based on where I am. Plus,
Can't do it from. Okay.
persons who
Okay.
know me since COVID know that I might be the only person with a laptop that doesn't have a built-in webcam. So I'm
I
protected
can't.
from
Okay.
being seen.
Okay. But Sam's voice, when you hear that voice, it's one of those voices like you hear Miss Lou's voice on the radio, that's Miss Lou. That's how Sam is becoming to us here in Jamaica and I guess across the Caribbean too. So we thank you, Sam, and we thank Allgate for being one of our sponsors, along with the Caribbean College of Family Physicians, for this webinar this evening. And we want to press on. Our final presenter this evening is Dr. Pate Robinson, and she is another diamond, and I should say diamond in the making too, because she's still very young. Not well, yes, Dr. Pate Robinson is still quite young in terms of her future and what she can do and how she can progress the development of medicine and healthcare for us here in Jamaica, and what she has already done. If she keeps doing what she has already done, boy, we have, Dr. Pate Robinson, there's a lot for us to look forward to. So we want to welcome you here this evening. And I guess a little bit on Dr. Pate Robinson. I'll tell you that she is she's with the University of the West Indies, and she did her training there, her MBBS, and her internship in Jamaica and the Bahamas. And she did her training in wellness specialist in Japan in 2007, and completed her DMA in internal medicine and a fellowship in internal infectious diseases at the University of the West Indies. She is a consultant and associate lecturer with the Department of Medicine at the university, and her major role is managing the clinical services at CHAIRS and CHARES, and she sits on the institution's COVID task force. This is where we do a lot of studies, papers and treatment and day-to-day care of patients who have oh Lord, here's the word. We've had Kathy, what's happened? Speak. Patients, CHAIRS. Tell us 2 seconds about CHAIRS.
Well, CHAIRS is our research, education, and clinical care treatment site for HIV. And so we do a number of things there, including prevention services for HIV and treatment services. So apart from trying to really enhance the knowledge of HIV in our population. So we're also actively engaged in research.
Thank you. Yes, so this is I was trying to remember. This is the biggest area in which we look about HIV patients in Jamaica. This is the biggest area set up, I think, by Dr. Brenda and Professor Bain some years ago. Had something to do, a lot to do with this as well.
There were a number of people, but yes, Prof. Bain was
and
one initial.
William Brown, I think a GP, family physician, also had a lot to do with it as well. So but back to yourself, Dr. Pate Robinson has been the HIV, oh Lord, let me just get back to where I was. The International Society of Infectious Diseases and the Medical Association of Jamaica. This is part of her associations. The subject of her research studies include sickle cell hepatopathy, sepsis and chikungunya. And she's married with 2 kids. You know, she's into family big time. So, Dr. Pate Robinson, we are going to listen to you now speak with us on the presentation, diagnosis, treatment, and prevention in adult population of this flu virus that we are talking about all evening here. Over to you, Dr. Robinson.
All right. So, good evening, everyone. I am just going to see if this will allow me to start. There we go. All right. So I hope you all can see this clearly. I wanted to go for some milder colors today, but we really are talking about respiratory illnesses in the current, what should we call it? Currently prolonged flu season, because it has been unusually long for the Northern Hemisphere. We've had 2 very good presenters who mentioned a lot of the details of the epidemiology of what's happening, who have talked about our situation here in Jamaica and the relation that has to what's going on globally. So I'm going to focus a little more on adult disease, and we're going to talk a little bit more about the practical aspects of dealing with this in the adult population. So we'll talk about all these different sub areas. So I won't go into the level of detail on seasonal flu that Prof. Christie did, because she covered the majority of the information and, you know, basically all the information, because there's a lot of overlap between child and adult. But I just wanted to mention a few additional things. The flu vaccine, you know, since we had COVID, a lot of people have really felt very unsure about vaccines in general. A lot of people are afraid of what they might do. And so vaccine uptake and usage has not been so great since COVID came around and sort of died back into a regular circulating virus. Now, the influenza vaccine is produced yearly, takes a couple months to produce, and is trying to predict what will be the predominant circulating strains for that year's upcoming flu season. Now, influenza A would be the group of influenza viruses that have pandemic potential and tend to cause more severe widespread outbreaks. And influenza B are the somewhat less common epidemic strains that tend to be more seasonally circulating. They can form epidemics and pandemics, but much less so than influenza A strains. And C and D are of lesser concern in terms of clinical severity of illness. And the influenza vaccines will usually have 2 type A and 1 type B. So we use that to help to give us some protection. The protection afforded by the influenza vaccine, which, as Prof. Christie mentioned, is not a live vaccine, so you can't get the flu from it, although a lot of people feel that they do get sick when they get it. Sometimes that may be related to catching other viruses that are circulating rather than necessarily being sick from the flu vaccine itself, because it can't really give you an influenza-like illness, but it will give you an immune response. So you may have pain at the injection site and so on. But the flu vaccine is one of the things that when we have a good prediction that year, such as in 2019 with the H1N1 strain, you get 100% protection almost if you take the flu vaccine. But if we're not taking it yearly, then we're not getting the benefit of it. And even though the protection may vary from year to year for the strains that are circulating most aggressively, there is some protection and cross protection provided, which is why even though this year's flu vaccine isn't specifically able to target these variant flu strains that we have going around, it still provides significant protection. So don't pay too much attention to the super flu terms that people are throwing around. That one almost falls in the realm of fake news, according to Trump. So just take that with a grain of salt. It is a more challenging flu season and a bit prolonged this year with more severe illness earlier. And there are a lot of reasons that are being looked at for that. Now, the flu vaccine provides protection from about September to April. For those of us in the Northern Hemisphere, that's the usual time period for flu season, tied somewhat to winter and spring in the more temperate zone. But we have, as you all would have noticed lately, we are getting that northern weather coming closer to us, and it's having a big impact. Now, the influenza virus that we are dealing with lately, this variant strain of H3N2, is or has been particularly challenging for high-risk groups in the adult population. As Prof. Christie said, the children are getting the more severe illness, but adults are getting at least more common moderate illness, and you have higher risk groups. The groups mentioned by Prof. Christie overlap with the adult population, not just the children, although we have a different spread of neurologic disorders causing challenges and not so much those congenital diseases and injuries in babies. But our elderly population, anybody over 60, although some people will argue that they're not old yet, and to a great extent you're not, but your immune system in your body is a little less robust and not as able to provide the protection that you want. So those who are over 60 are going to be at more risk of moderate to severe illness. Pregnant women, they have a lot going on, and then it's a double whammy because it's risk for the mother and sometimes risk for the child. And those with underlying medical conditions, whether it's significant cardiovascular disease, any organ failure syndromes, or any immunocompromising conditions. So, and if those conditions are uncontrolled, then the effect of having this pro-inflammatory viral infection can sometimes tip the balance and lead to an early need for hospitalization. So high-risk groups really do have to be cautious, and we really do want to encourage everybody to get their vaccine each year. Now, we already heard about this new subclade, and as Prof. Christie said, influenza viruses recombine a lot. They meet a friend and say, hey, I'll give you my jacket, you give me your pants, and let's mix and match our clothes. And that's what the influenza virus does in every season. The good thing is that when we have mix and match between human strains and animal strains, the transmission between humans is less effective, but sometimes we get a really aggressive crossover. Thankfully, the current flu vaccine from this recent flu season is partially effective against even the variant subclade K strains, and that's still providing significant protection to reduce severity of illness and the need for hospitalization. So even though the flu vaccine doesn't have this particular strain, the protection it provides is sufficient to reduce the risk. And as Prof. Christie had mentioned, there's a lot of data coming out of a lot of the European countries where they have more investigative capabilities on a molecular study basis, and they can look in more detail at vaccine effectiveness, and it can be anywhere between 30 to 60%. In this flu season, it's a little reduced for the adults, 32 to 39% for these subclade K strains, but 72 to 75% in children and adolescents. So if we were vaccinating our kids a little more aggressively with flu vaccine this year, they would have gotten a lot more protection. And the director of the World Influenza Center really, came out in the news to let everybody know that even though the season has been unusually severe with earlier moderate to severe symptoms, there isn't any particular indicator that the virus is evolving away from the control that can be provided by vaccination. So that's encouraging when we look at the actual numbers and what's happening, that things are not in the realm of sci-fi just yet. So this subclade K strain was first detected in Norway and followed by the United Kingdom, and their influenza season and this outbreak, if we want to call it that, started 4 to 5 weeks earlier than they would typically see it. But there was a fall off by December in many of the areas that were finding these early flu spikes. Japan was having some challenges, Australia was having some challenges, and one of the concerns was that even though from September to December we had spikes that were reducing thereafter, everybody was looking out for the possibility of a spike in the early part of this year, which some of us have been seeing. And you saw the data from Dr. Webster-Carr's assessment. In the US and Australia, by December, they were reporting that there was a lot of illness, lots of hospitalizations, and a significant proportion of deaths from this subclade K strain, because it has been the predominant circulating strain since at least the middle of the flu season. So more of the illness is attributable to it, and between the children and the adults, more moderate to severe disease for this flu season. So that has led to a lot of extra burden on the healthcare system. And we're very close with our friends and family overseas. People are traveling a lot more, and so we're sharing and we're bringing it home. And so we need to protect the people around us, not just protect ourselves. So when we look at what we see in adults, it's a little bit different from the children, although as you get older each decade, so once you go over 60, 70, 80, 90, you're going to find that the variety of symptoms more mimics those of middle-aged, I shouldn't say middle-aged, but middle-aged children. Forgive me, Prof. Christie. And so you may see more gastrointestinal symptoms in the older adult. But the fever, chills, and body aches, the muscle and joint pains are the predominant symptoms. And that has been the case throughout many different countries. Those are the symptoms that will be seen the most. Now, of course, you may have your cough, your sore throat, your runny nose. You may have headaches. You may have a lot of other symptoms that can come with any viral infection. But the fever and chills and body aches with the fatigue that is sometimes a little more profound than expected are the predominant features that we're looking at. Now, when we say cold versus flu, we're referring to influenza virus, which has a little more potential for outbreaks, a little bit more potential for severe disease, and colds tend to be a little more self-limiting from a wide variety of viruses with varying potentials for an effect on our systems, whether respiratory tract, nervous system, or otherwise. So fever is common between influenza and COVID-19 in terms of the coronavirus that causes COVID-19. Cough is common across all of them. Loss of taste and smell is more common with COVID, not so common with flu, occasionally with some cold viruses. Fatigue is very common with influenza, but you may get it from COVID or a common cold. So when you look at these patterns, you see that there's a lot of overlap. And that's why you can't depend on looking at your symptoms to say, oh, I have COVID or I have influenza. Testing becomes very important. But there are some characteristics that we want you to pay attention to. And if you are more high risk, then you should not ignore the symptoms when you get them. But for those who are high risk, it's everything and you pay close attention. But for anybody, whether high risk or not, these symptoms are more concerning. So the fever is very high. The temperature is over 103 degrees Fahrenheit, that's the same as 39.4 degrees Celsius. That's very concerning for multiple reasons, including the possibility of lowering the seizure threshold. So people who may or may not have had fits before may have seizures and alterations in their mental function, cognitive function. If a fever is lasting greater than 3 days, that's also concerning. It can happen with many viruses, but more than 3 days makes you concerned for severity, for the viral process and your immune response, but also for the possibility of secondary bacterial infections. Chills and rigors come with more severe inflammation and fever processes. And so those, when they're commonly happening, that's not necessarily a good sign. You should pay attention to that. If your cough is persistent, worsening, if there's increasing sputum production, or there are alterations in color, it's, you had white or pale yellow sputum and now it's becoming yellow or green, or there are blood streaks or there are clots. Those are not good signs. If there's persistent or worsening shortness of breath, low levels of oxygenation, unusual drowsiness, chest pain, any loss of consciousness, all of these features are ones that should prompt us to seek a deeper evaluation. And depending on what's available to you, if you're a physician in your office, a healthcare provider, then to get somebody into maybe an emergency room for a more detailed assessment so that we don't miss those who are going to deteriorate and need more support. So viral pneumonia is one of the complications of having an influenza infection. And you're more likely, if you do a chest x-ray, you're more likely to see ground glass opacities, effects on the periphery, and a more diffuse picture. Whereas a bacterial pneumonia tends to give you consolidation, large but more discrete areas where you have more debris or fluid density, opacification of your lung tissue. And you're more likely to have purulent secretions in a bacterial pneumonia, but it doesn't mean that you cannot have purulent secretions in a viral pneumonia. So there is a lot of overlap. There is an increased risk with moderate to severe illness that you could have respiratory failure with a type 1 respiratory failure where your oxygen levels will be decreased and you'll need support with oxygen, or type 2 respiratory failure where you now go into carbon dioxide overload because you're not able to clear your waste gases. And thankfully, COVID helped out a little bit with some of what's available. And we now have high flow nasal cannula oxygen available in most of our hospitals, so that somebody who is in between the need for regular oxygen support and ventilatory support on a mechanical ventilator can get high flow nasal cannula oxygen and sometimes recover without needing to be intubated and ventilated. So that is quite helpful. Now, typically we think about sepsis or systemic inflammation due to an active infection as more relating to bacterial illnesses. But the inflammatory drive in a viral infection can be significant. I know most of us would be familiar with SIRS criteria, the systemic inflammatory response syndrome. The criteria wasn't good at capturing everybody with sepsis. And even the newer criteria like the SOFA and Q-SOFA scores and newer variations of the SOFA score still miss a few people. So it's important to think about sepsis when you have anybody more moderate to severe illness coming into your office or your emergency room, because the systemic inflammatory response that occurs in sepsis could lead to a very rapid deterioration with poor outcomes and requires us to move a little more quickly to get that person supported so that they don't deteriorate. So the SIRS criteria really focus on 2 out of 4 of abnormal temperature, respiratory rate, heart rate, and white cell count. The SOFA score went into a little bit more. So you had different points for different criteria. You had respiratory, coagulation, liver function, cardiovascular, neurologic, and renal criteria. It's easy to find online. You can look it up. And they did a quick SOFA score to assist in a pinch that you can quickly assess whether someone has altered mental status, heart rate over 100, or respiratory rate over 22, and say that, okay, this person is more likely to have sepsis. I need to take a deeper look. So when you see that, that should trigger a little bit more care in the depth of evaluation and a lower threshold to refer for further assistance, especially if you're in an office and you have limited support available. So what about diagnosis? Prof. Christie did a great job of going through the testing modalities that are available. So I'm going to focus a little bit more on the generally available practical things. As she mentioned, the sensitivity and specificity of the rapid test kits is highly variable. It also depends very much on when you're testing. And even with PCR, your testing window tends to be from maybe about day 2 to day 78. So you really want to catch somebody in that early phase of illness where the viral numbers are increasing rapidly. So day 1, 2, 3 are the best days to do your testing. And whether you're doing a rapid antigen test or you're doing PCR, we more commonly now use these very thin flock swabs that don't have any organic material. They're synthetic. So you can use them for these antigen test kits, but you can also use these for PCR. And if you're in a hospital or in an emergency room, you may use a similar process to collect sample for both. You may have seen these test kits in your local pharmacy. They have become far more popular since COVID came about. And I haven't really seen the triple ones with RSV. This is just one brand. There are quite a few available in Jamaica now. And if you are a physician, you may carry different brands in your office, but they're very easy to use. And it's not the worst thing to have them or to run out to your local pharmacy and get it if you suspect that that's what's happening to you. You're developing a respiratory illness. It's been, the first couple of days. You can still test and it may be useful as long as the viral numbers are quite high. But our National Influenza Center does the more detailed or more robust testing. They may use ELISA tests. They may use PCR, and that, depending on how quickly we can get testing done, we can get very reliable confirmation. So we should try to test a little bit more often. I know cost is often a constraint, but when we know that we have COVID, then we have an algorithm for approaching that. If we know that we're dealing with influenza, we have an algorithm for approaching that. If you don't really know which one you're dealing with, then you can't really take hold of the antiviral therapies because you don't know which one you should use, or you're stabbing in the dark and you may be treating with more than you need to, and that's also going to come at increased cost. So testing is helpful to differentiate what we're dealing with and help us to target our treatment appropriately. Now, whether it's colds, influenza, COVID-19, or whichever other respiratory illness, general supportive measures are always helpful and should be engaged from day one. And if it's flu season and you or your patients are more vulnerable, then encourage them to engage in healthier habits and preventative habits. Hydration is critical for us. We're in the tropics. Yes, we've been having cold fronts recently, but it's still quite hot most of the time. And if you're in the sun, your insensible fluid losses, even as adults, can have an increase, well, come with an increased risk for organ damage. And if you already have vulnerable organs, say you have high blood pressure, your kidneys have very early kidney disease, you're not taking enough fluids, you get the influenza virus, and you don't feel to eat, don't feel to drink, you get dehydrated, you could have permanent worsened kidney function because of damages during that period of illness. So it's important to pay attention to hydration, not just for children. And for those with organ failure, we have to be careful that we don't overload them. If you have heart failure or kidney failure, you may not be able to tolerate high levels of fluid. So then you have to be more cautious. And if you're in doubt, check with your doctor. Liver failure, not as commonly seen, but if you do have liver failure, then you also need to be careful about fluid overload, depending on how bad it is. Now, antihistamines like cetirizine, fexofenadine are often used to reduce itchiness, swelling of the tissues, the stuffiness, a runny nose, and so on. And they can be helpful. Bear in mind that dry mouth is very common with them. And physical measures to clear mucus are very helpful, especially in the early phases, but regardless, straight throughout. So we don't use saline nose drops as often for adults, but they are helpful because that is going to help to thin out and loosen the secretions in the respiratory passage, upper respiratory passages. But we do have saline sprays and washes, which are a little more aggressive and easier for adults to use than children. So they have a little bit more available for the adults. And, it doesn't have to be a neti pot. There are quite a few people who swear by that, but some people don't really tolerate it very well. So choose what you can tolerate and use it as often as you can to help clear the mucus so the mucus doesn't get thick, hard, and stuck and block up the smaller passages. Menthol saline steam inhalation is very useful. Either menthol crystals or a little Vicks in a bowl of bubbling boiling water with salt, cover with a sheet, steam, and help to get some of those thick bits of hardened or thickened mucus to be washed down out of your upper respiratory tract so you can have clearer passages, less likelihood of ear infections, especially for those who already have pre-existing respiratory issues. And if you have chronic allergic rhinitis, you have long-term sinus problems that are not well controlled, you would want to be a little more careful in flu season because you are more vulnerable because your respiratory tract already does not have great function. For those with asthma, you also need to be more careful because an upper respiratory tract or lower respiratory tract infection can sometimes push the inflammation in the respiratory tract and precipitate an asthma attack. So we do have to be careful of that. General protective things are helpful, whether as a preventative measure or in the setting of an early infection. Zinc and vitamin C, if you don't have particular contraindications for those, are helpful for enzymatic function, boosting immune function, getting enough sleep, which the average person seems to not want to get. I mean, we all want more sleep, but it's necessary for your body's recovery and maintenance of good health, especially as we get older. So the older person who is more vulnerable needs to be a little more careful of that. Fresh fruits and vegetables are always critical. Limiting exercise and overexertion. I had to mention this because there are especially a lot of younger adults, middle-aged people think that, you should sweat out the fever, you should go to the gym and work out aggressively because you're working out the flu and getting rid of it faster. But we do have to be careful. Sometimes that can precipitate rhabdomyolysis. And that can knock the kidneys, that can put you in hospital. Sometimes that can lead to more aggressive inflammation in the muscles. And that can also, in some people, increase the risk of cardiac muscle inflammation. So we do have to be careful to avoid excess exertion in the setting of an acute influenza infection. So if you have a lot of respiratory signs and symptoms, maybe take it a little easier, get a little more rest, drink a little more water, go to sleep on time, eat healthy, and try to recover before you push hard again. And Prof. Christie already mentioned some of the challenges with non-steroidal anti-inflammatory drugs, including things like, if you have dengue and it's not flu or a cold, or you have dengue with the flu and the cold, then you want to avoid NSAIDs because you don't want hemorrhagic dengue syndrome. So those are some general things to think about. Now, Prof. Christie already mentioned a lot of the antivirals. I will say that generally speaking, Tamiflu is mostly readily available in Jamaica. Paxlovid has been here on and off, but it's not a regular use drug for us. It's still pretty expensive. So that's not something in regular supply. But Tamiflu is relatively easy to get most of the time. And so, as you can see here, Tamiflu for influenza, it's 1 tablet twice a day for 5 days. Physician has to prescribe it. And you really need to start these things early, because if you think, okay, well, I'm not that sick, let me watch it and see, you could take yourself out of the window period, or you could let your patients go out of the window period for the greatest utility of these drugs. They don't do as much as we would want to, so starting them early means you get the most out of them. And for those who will progress to severe illness, if you don't start them early before they're actually severe, they may not get much benefit from them. And you could perhaps have cut down their hospitalization and maybe reduce the level of severity. So that's something to think about, using them earlier, especially for those who are high risk. I understand that if you're generally, average young person, healthy, you're not going to want to do that. But if you have any increased risk, you really should consider it. And that's why the testing becomes important, because if you know you have influenza and you're high risk, then you really should get an anti-influenza antiviral. So try and get these started within 48 hours of onset of symptoms, whether that is cold and flu, sore throat, stuffiness, runny nose, fever, muscle aches and pains, whatever it is. 48 hours from symptom onset is when you want to start within 48 hours from symptom onset is when you want to start your antiviral. And so please don't wait, especially if it's somebody high risk. There are newer antiviral drugs available in other countries. We don't have many of them here yet. And so things like the Xofluza, the baloxavir that Prof mentioned, the peramivir and the zanamivir, we don't really have them here. And so we really don't use them very often. As Prof mentioned, Tamiflu may have more GI side effects than some of the newer agents. And there are some concerns with the neuropsychiatric effects in some of the children. But generally speaking, they're well tolerated for the average person. But you would have to advise, if you're prescribing them to any of your patients, advise them on the things to look out for side effects. So prevention. And this is where I think we get the biggest bang for our buck. If you prevent getting the illness, if you avoid contracting the infection, then you really don't give the virus an opportunity to damage your system. You can't always avoid getting it, but we can moderate the effect. part of that is trying to maintain health and wellness in between whenever we're exposed to an illness. Vaccination is also helpful. We mentioned already that the current flu vaccine is actually somewhat protective for these variant strains, like the subclade K strain of the H3N2 that is circulating and causing this sort of super flu that everybody's talking about. So the flu vaccine is still helpful. And it's not that this virus is super bad, but there is a trend towards more severe illness. We have a little less protection in the background. A lot less people have taken the flu vaccine in recent years, so our vaccine uptake is very low, and that means that background protection in our population, and overseas it's the same, is also lower than it should be. So we have less protection individually, and we're more likely to spread it to the people around us. And so we do have to be a little more careful in periods like this, so the flu season. And bear in mind that when you look at what's happening, generally speaking, whether from an economic perspective, post-Melissa issues, a lot of people have multiple comorbid illnesses. They might be dealing with high blood pressure, diabetes, they might have other things, and they're already struggling to manage those health conditions. And then you add something like influenza, where you are increasing inflammation and taking a toll on the overall system. And for people who are already challenged with trying to manage other illnesses, that can sometimes be, you know, the straw that broke the camel's back and puts you into hospital. So we do need to pay attention and really try to encourage each other, our friends and family, our patients, to take the flu vaccine. It's not the worst thing. And there, you know, when somebody goes through a severe illness and you look back at the choices you made, will we be happy that we avoided getting the vaccine if we really come out at the other end having lost function? And that's something I always try to think about and try to have everybody else think about, because you want to be happy with the choices that you make. So some last few things on the prevention side. If you if you have a respiratory illness, doctor, nurse, street sweeper, whoever, please stay away from high-risk people. So if you have elderly people in your environment, wear a mask around them, stay out of their spaces, wash your hands, carry your sanitizer, have good cough etiquette. You know, they have so many videos since COVID, you cough into your elbow or you use tissue to sneeze into, whatever it is. Try to reduce the transmission to people who are vulnerable. If someone is ill in a household with multiple people, it's important not just for hand hygiene to happen regularly. And anytime you cough or sneeze, you need to wash your hands or sanitize. But you also need to disinfect surfaces, especially high-touch surfaces, counters, tabletops, doorknobs, wherever people will touch frequently, need to be cleaned frequently, sanitized, spray them with alcohol. I mean, you can't spray varnished furniture with alcohol, but you can wipe it down. You can use things like peroxide and so on. So, you know, whether it is bleach, peroxide, alcohol, or some other kind of appropriate disinfectant. If you are indoors and you don't have good ventilation, then viruses will circulate and everybody breathing the same air is at the same level of risk. So it's important to have good ventilation, but it's also important that everybody in that situation, if one person is sick in the room, everybody should be wearing a mask. So the person who is sick is less likely to spread their droplets to the air in the room, and the other people who are in the room are less likely to get the droplets into their respiratory tract. So you have better protection if everybody's wearing a mask. So just pay attention to those things. And if you're at work then you have to be careful that you are not, causing transmission so more people are sick. So be careful, okay? Influenza is very contagious. Maybe not as bad as measles, but a lot of viruses these days are much more effectively transmitted because of how we live. So communal spaces, try to protect yourself and those around you. And really do please consider vaccination. It makes a difference. So last few things. Sorry. So last few things. When we look at hand hygiene, this is not a good quality image, but you will find these WHO 5 moments of, sorry about that. My battery was switching over. So you'll find these WHO 5 moments of hand hygiene online in different colors, but you want to pay attention to cleaning your hands, whether with an alcohol-based sanitizer or hand washing at all these moments in the healthcare setting. And that translates to how you manage if someone is sick at home as well. Please bear in mind that these as well, they're also on the WHO website and easily available online. How to hand rub. So when you're using sanitizer, if you have visible soil, dirt, if you contacted body fluids with your hands, then sanitizer is not appropriate. You need to wash. If you're in an environment where there's a spore-forming infection like C. difficile, diarrhea, then you need to hand wash because spores are not killed by alcohol, okay? But if it's something simpler, you can use sanitizer and rub according to these procedures, so 20 to 30 seconds with a decent amount so you can spread it on all the surfaces in the creases and so on. And for hand washing, it's recommended that you do a minimum of 40 seconds, but preferably a whole minute, paying attention to all the different creases and crevices on your hands, okay? So just a reminder on that. And then, if our vaccine uptake is better, then we are less likely to transmit to others who are at risk, who we're taking care of if we're healthcare workers. And that's something that as a healthcare worker is our responsibility. And then if you're at home taking care of someone or you work as a caregiver, that's also something you need to consider, how to protect the people you're caring for and not just your family or yourself. So just to mention that. So if we had better uptake, we would have less people getting sick, especially now when money is running. So, hopefully I haven't put you to sleep and taken too much time, but that's it, unless you have questions.
Thank you, Dr. Pate Robinson. We will be entering our Q&A for everyone, all the doctors participating just next. Really a very, complete and covering from the general picture to the nitty-gritty again. So we're having a lot of reinforcement and with new little things coming in. The Tamiflu, I'll start off the question with the question to you, Dr. Pate Robinson. The Tamiflu vaccine, giving the access to Tamiflu within 2 days of the symptoms. I have not, this is new to me. And you're saying that this is all of us, doctors, not just when they're coming to hospital, but us in the community here now, speak to us.
When you're looking at all the studies that were done with Tamiflu, okay, it's not going to do as much as we want. There are limitations to these drugs. So if we want the maximum that they can give. For somebody who is high risk of severe illness, you really do have to start it early because it has to get in your system and start preventing the virus from escalating so that you can nip things in the bud early, cut down how long you might have to be in hospital, hopefully reduce the need to be in hospital at all. Once you get well established with the infection, halting the process is so much harder and the drugs really have less effect. We still use them because any little benefit we can get at that point is better than none. But then where before you might have gotten 50% of help, maybe you cut down to 10 or 15% of help. It's still something, but it's not as effective. So you may still end up with complications for those who are truly at high risk.
So the access to the Tamiflu,
it's much better since COVID. A lot of things, even though we have supply issues, is a lot better since COVID. So a lot of private pharmacies, not just government pharmacies and so on, but a lot of private pharmacies now carry Tamiflu. And so if you give someone a prescription, they will be able to access it in many of the bigger pharmacies.
Wonderful to hear that. That's, let's hear that Tamiflu is available in our general pharmacies. So that is something, access to Tamiflu. And one of the things that we've noticed, this is a question thrown out there, the children just getting one illness and then going on to get another. They barely get better before they get another. They seem to have been so run down and so the immune system so demolished that before they can have a week of good health, I've been noticing it this flu season, they're sick again. And so they seem to be going for many weeks ill. How do we, and this is to everyone, how do we deal with this? How do we deal with this? We can hear from Prof. Celia Christie or from Dr. Pate Robinson about this.
This is very sad. And I think as healthcare providers, we have to be the ones in the forefront to make sure that we diagnose early and we put in place all the interventions so that the children don't go on to get these complications. Yes, it is true that if you have an underlying illness, you're more likely to have these complications. But to my mind, we have the parameters in place to keep these children out of hospital and to more or less help them to get better, whether it is they have influenza or if they have the more complicated complications like the vomiting with dehydration or the pneumonias and so on. If we work with them, we can help them to have a better life, both for the normal child who is going to school and for the child who has underlying disease. I think the doctors and the healthcare team and the families need to work together to improve and give the best kind of holistic health to our children and to our adolescents. And again, it's a family disease.
Yeah.
So we have to bear in mind that everybody, needs to be, it's all hands on deck.
Right. And of course, this whole idea of the yearly vaccination, we need to did this, yes.
Annual vaccination for everybody, all the children who are over 5. Mm-hmm.
Because what you're both saying here is that the vaccination yearly gives an additional,
it makes a difference.
It's not even just getting it 1 year is not as good as having the pattern of having taken it over a period of time, because you have a sort of fallback effect on what's already in your system to help prevent illness this year. Something else. Other questions? Let me see here. No. this whole idea of the bird flu, Dr. Christie, Professor Christie. Tell me about bird flu and that. It's been so near, yet still
I
so
had to throw
far.
it in. I really had to throw it in. Karen, no harm meant. We need to think about it. We're living in after COVID. We know that there's lots of different things that are out there that can become dangerous. Things that are far, far, far away may, be a problem.
Yes, it's not that far.
So it's not that far. Cayman is just a flight away, and we have flights from Cayman every day, sometimes two. Same thing with New York. They have a bird, a lot of birds died recently. Just 2 days ago, I saw that, and the preliminary test is that it's from avian influenza, and that can kill.
Yes.
So I said it in my talk, and I think we really need to pay attention to it here. And as healthcare providers, we need to ask our patients if they have been exposed to it. I don't know if children will see a dead bird outside and go and play with it. I don't know, but we need to ask.
Yes, Dr. Webster-Carr, any comments based on what you've been hearing here this evening about the severity of what might be here right now, and also the need to pick it up quickly and run with it. How are we coping with that part of things?
I'm not sure I understand the question.
What we're hearing is that there needs to be quick diagnosis of the disorders, because if we want to manage it and if we want to prevent more severe side effects. How are we going to access this through the government service?
Well, we don't have the rapid test, so it goes on to the NIC. So that is not rapid because the NIC takes probably a week for us to get back the results. And so I'm not sure.
Okay.
And there has not been any discussion really on rapid test use in public facilities. So it's something that can be raised and that I can raise.
And from what we're hearing tonight, it seems we do need to diagnose and treat with some alacrity in terms of saving the hospitalizations, preventing that, and perhaps saving morbidity and life. I'm opening that to a little discussion amongst the three of you. A quick point, each person.
Well, I would say, if you think about it, with how decentralized things are, a lot more is available out there in the community than used to happen. Not everything is hospital-based anymore. So each of us has a potential to be responsible to protect our family in that way, where we could go and pick up a kit. In the States, I recommend that you keep a few at home. I don't know how well that would work out for the average Jamaican family. Some people are just not going to be able to do that. But you could go to the pharmacy tomorrow and you could get a kit to test. And if you, the person who is most ill, or the person who is ill at the moment, comes back positive, then you know that you can get treated earlier and even then consider preventative care for your family members so that they are less likely to get more ill. So that now comes partly into the realm of what we can do for ourselves, not just what the physician or healthcare providers can do. And we all have somebody in our neighborhood or community who, if we don't have the medical expertise, there's somebody that we can check with. There are always, emergency rooms you can call and ask for assistance with answering some of those questions. You have community doctors. So it's not always just what you need to do as a physician, but you also need to encourage people to be more proactive for themselves and their families, because we each have that responsibility.
Okay, thanks. Any other comments? Dr. Christie?
Well said, Dr. Pate Robinson.
Okay.
It's a collaborative initiative for everyone.
All right, thank you. I see a question here from Paula Lawrence. She's asking if this PowerPoint would be available. At a later date. I'm going to leave that question for now because CCFP admin would need to respond to that. There's another question here from Rohan Lawrence. Any recommendations on the avoidance utilization of our neti pot? I think we mentioned something about it before, but neti pot irrigation and frequent use of antihistamines as it relates to complications in patients with comorbidities that already have them immunocompromised. Anything more to add about the neti pot?
I will add a little bit, maybe not specifically for the neti pot, because salt and water, if it's clean water, if it's boiled water that you use to make your solution, or you purchase a pre-packaged solution, that's not of any real significant increased risk. I mean, if you have high blood pressure and you're not taking pills for a month and your pressure is in the 200s over 100s, and sure, don't go use the neti pot because you need to get your pressure down before you add all that salt to your system. But you are trying to flush the system. So, that is an individual risk factor issue. But generally speaking, using these salt solutions for flushing the airways is not of any great risk for the average person if it's done safely, sterile or clean. But in terms of the antihistamines, I would mention something from the comorbidities aspect. So some antihistamines, when you use them routinely, may come with some challenges for the adult who has high cholesterol or the child who may be more susceptible to bradycardia. There are some rare side effects that can happen. So, for example, fexofenadine and cetirizine are known to potentially increase cholesterol levels if you're using them chronically. Doesn't happen often, doesn't happen to everyone, but it's a potential side effect. So if you already have high cholesterol or you're on them very long term and you see that your cholesterol is going up, you'll have to switch out to something else like loratadine. And then there are some children, not sure so much about the adult side of it, because I haven't really seen much data on the adults, but there is some potential for occasional fexofenadine to cause bradycardia in some children or young adults. So it's not that these things are often very dangerous, but this tends to happen with long-term use. And so that's something that would be in the realm of you visiting your doctor regularly because you're having these issues. Then maybe you need to work out a better system with them to have better control without having to stick to being on these things every single day for the average person.
Thank you. I see here Dr. Zin Wu has two quick questions. Asking about how can he or she convince patients who thinks that vaccines were created by Bill Gates and people like that, and that they have, the usual thing to hurt people. And also saying that when they used to work at KPH, they needed consultant's signature to dispense Tamiflu from the pharmacy. So has there been a big change? And that was in 2020. Has there been a big change in how things are done now? So those are two questions. Dr. Pate Robinson, perhaps you can take the second part, Tamiflu.
All right. So with the Tamiflu, if you're in a hospital setting, then depending on the institution, you may need the consultant to sign off on it, because that is not necessarily a decision that would be left with junior physicians. If you're out in GP world, then it really just is depending on availability and supplies. But in the hospital setting, the usage may be more limited so that we can use it for those who really need it and not use it inappropriately, because a lot of hospitals will have varying categories of staff. So that decision often with the consultant.
So when you're out as a GP, remember you have quite a responsibility, because it's your decision to make. So you don't, it's you to look at what's there, what you're presented with, and a decision to make. And then we have Dr. I think we can ask Prof. Christie this question about the Bill Gates thing that keeps coming up endlessly here in Jamaica and across the world.
Bill Gates is a very, very powerful man. And he has done a lot. He and his wife have done a lot for pushing vaccines and making vaccines available to the developed and even the developed world. It's unfortunate that they're being vilified for what they're doing, but I think they did a wonderful job, and they're still doing a wonderful job, and I think for the most part they have done excellent work. And I think what we need to do is try to quell the negative energy and the negative talk around their work in the vaccine space. Most of these comments came up, and most of the discussion, negative energy, came up during the COVID-19 pandemic. And as you know, there's still a lot of conspiracy theories there. We were under a lot of stress, with the lockdowns and with these illnesses and family members dying and so on. It was a lot for countries and for people to take. But for the most part, I think they have done an excellent job, and they are to be commended.
Thank you for that response. So we would like to thank everyone who is still with us for being with us. I would like to thank our three presenters this evening. We're going to hand over now to, what am I supposed to do something here quickly?
There were also several other questions which were answered in the chat. I think the administrator would be able to speak to that.
Okay.
I answered about 12 questions.
Oh, yeah. Okay. Okay.
So, thank you so much, Prof.
Well, we want to thank you for that. I'm going to just make a quick announcement here before handing over for the vote of thanks to Dr. Dane Levy. I just really want for myself to say how very, very appreciative we are to our speakers. Dr. Celia Christie, keep on with that, Dr. Business,
It's okay.
Emeritus, Okay, Emeritus. Professor Emeritus Christie. I keep on saying to myself that this is fun. Yeah, this woman for all ages and times. I cannot take from her that emeritus. Dr. Catherine Pate Robinson and Dr. Karen Webster-Carr. You've been with us the whole evening, and it's amazing. Thank you so much. And we're going to hand over to Dr. Dane Levy in a moment. I just have to say to everyone here that the Caribbean College of Family Physicians has another meeting scheduled for later February 22. What happened was that because of the Hurricane Melissa last year, the December 11th meeting was canceled. because many of the doctors were actually affected adversely personally. So the pain webinar, parts 1 and 2, has been rescheduled for the 19th of February, Thursday evening, and the 22nd of February, Sunday afternoon. Now, Dr. Dane Levy, please, over to you, sir. Please, you do the vote of thanks and closing remarks, and you see us out, sir. And I'm just saying good night. Thanks to everyone who has attended. Thanks to all the persons, doctors, non-doctors, people from other genres who are in other professions. This is One Health. We all make this bird flu. You know, this is One Health. So we make the world a better place and a safer place. So over now to Dr. Dane Levy.
Thanks, Arna. Good night, everyone. Let me apologize for not having my video up, my camera up. I am in transit, so if I do that, I might lose connection. So I just wanted to say that this webinar, the cold and flu webinar, is very, very timely because we have seen the influx of patients in our practices, young and old, who are suffering from symptoms of the flu. And so, having heard the various different presenters and having heard these wonderful presentations, I think that we are now better able to serve our patients, to advise them as to what to do, and when they come into the office, to offer better advice and better treatment for them. So I think we have had a wonderful webinar. I think that's the general consensus, that we have all been fed very, very relevant information, for which we are very thankful, and getting updates. We heard from different angles. We heard regarding the children up to the adolescents, then the adults, of course. And of course, we heard about the flu virus, which has taken our communities by storm. And so, as I said before, I think have all been informed. We have all been gotten a great revision regarding what we do, how we treat, what we should be looking out for, the various complications, when we should refer the patients that are most at risk, the symptoms that we should be seeing, and just getting the information that we need to address the situation regarding our patients and our communities as comprehensively and as adequately and efficiently as we can. So having said that, I just wanted to offer thanks on behalf of the Caribbean College of Family Physicians, of which I'm Jamaican chapter, of which I'm the honorary secretary. I want to thank our president for initiating the organization of this webinar in such a, very quick, very timely, and getting together such a wonderful, qualified, and informed panel of presenters in such a short time. Our moderator, Dr. Arna Brown-Morgan, did an excellent job, as she always does. But I think tonight she outdid herself. I think just in controlling, moderating, fielding the various questions, and just getting the kind of information that just made the webinar that much better and complete. I think she did an excellent job. Of course, also, we were, prayer was offered by Dr. Arlene Henry Dawkins, an executive member of the Caribbean College. And there's prayer can never be too much, of course. And when we pray, we know God does awesome things, great and mighty things. And so we thank her for offering prayer for the presenters, for the success of the webinar, and of course, for the success of the college. Just want to thank also all the presenters, beginning with Dr. Webster-Carr, who did a marvelous presentation, Professor Emeritus Dr. Christie, who also did a very, very wonderful presentation, very, very informative, touched on everything that was relevant to the treatment in children and adolescents, and generally gave us a really, really very valuable presentation. Dr. Pate Robinson as well, who closed us out. She also did a very excellent job regarding how we look at treating the adolescents, bringing into focus the use of Tamiflu, also focused on getting the diagnosis early and the value of early treatment. So I think that, thanks was never too much. And we're really, really very thankful to all of our presenters, all three of our presenters. I think they did excellently well. And we're really, really very thankful to them. Our Oldgate Solutions, they were facilitatory in presenting this webinar, and we always are indebted to them for the excellent and efficient manner in which Sam does his job. Sam, thank you. Founder and CEO of Oldgate Solutions, did an excellent job as well. I also want to thank forgive me for that noise that came in. I think the police are chasing someone, but nevertheless, I'm safe. So I'm saying that thanks to our administrator, Mrs. Lynn Thompson, and their staff, I think they were also involved in the organization of this webinar, and we're also thankful to each and everyone that participated, that were part of the organization team, that carried out their functions so efficiently. And of course, last but by no means least, want to thank my colleagues. I think there are over 500 colleagues and more than 500 colleagues that were on this webinar tonight. And I think, speaking for all of them, very, very thankful, very, very, very informative. And I think we were all better off for being here tonight, having this wonderful feast of knowledge. So thanks again on behalf of the Caribbean College of Family Physicians, Jamaican chapter, and just want to look forward to the next webinar, as Arna pointed out, that will be coming up later on in the month. Thanks again, and God bless you all. Night.
Night. Thank you so much, Doc. Appreciate it. And of course, thanks to Lynn and everyone, as you said before, everybody. Most importantly, thanking you all for joining us. 1,970 plus registered.
300. Wow.
A lot of persons, Doc, and many of you visited on YouTube, of course, joined us here on Zoom. Yeah. And so wherever you are, stay safe. It is Friday the 13th. We don't have Halloween here, but of course, stay safe out there.
By the way,
And
happy Valentine's Day to one and all.
there you
And
go.
Dr. Dane Levy, let me come in. Dr. Dane Levy, our esteemed Secretary of CCFP Jamaica, who has been doing the role of closing out thanks and vote of thanks for many, many years. Thank you, Dr. Levy. Thank you.
Thank you, Arna. God bless you.
Affects every area of medicine, from acute care to chronic disease and end-of-life management. The Caribbean College of Family Physicians, Jamaica chapter, presents a two-part pain management webinar series. Part 1 will be hosted live via Zoom on Thursday, February 19th, 2026, and Part 2 on Sunday, February 22, 2026. This series is designed for physicians and healthcare professionals seeking practical, evidence-based approaches to pain management. Part 1, which will be live Zoomed on February 19th, 2026, beginning at 6:35 p.m. Jamaica time, focuses on the common and complex pain presentations seen in everyday clinical practice. Part 2, which will be live via Zoom on Sunday, February 22nd, starting at 2 p.m. Jamaica time, explores multidisciplinary and psychosocial aspects of pain, including safe and effective prescribing. Sessions are led by experienced consultants and moderated to ensure relevance to general practice. Each webinar carries 2 CME hours, with certificates issued upon verified attendance and completion. Registration and payment details will be on our flyers, which are in circulation with separate registration portals for each day. Join us for both days of this essential pain management webinar series. Thursday, February 19th, 2026 at 6:35 p.m. and on Sunday, February 22nd, 2026 at 2 p.m. Zoom links for each day can be accessed below or on our flyer.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care, the Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global Impact, Regional Action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations, representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice. CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered. If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians. CCFP membership offers numerous benefits, including continuing medical education, professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies. Research and publications. Global connections. Join the Caribbean College of Family Physicians today, whether by direct membership, by chapter membership, and be part of a movement that is shaping a healthier future for the Caribbean. Together we can make a difference. Become a member and make a difference.